طيب, so this is an old case that I used to post on Twitter, but let's revise it one more time. So we have a 46-year-old male with a previous history of STEMI who was presented to the clinic with fever as well as pleuritic chest pain 2 to 3 weeks following CABG procedure or following coronary artery bypass graft procedure. All right, so he's presented with fever and pleuritic chest pain, and you were giving the following imaging. So what's the notable findings that you see here that will help in confirming your likely diagnosis? So if we look at this one, we can see that on the PHS X-ray, there is the presence of a two-lead pacemaker. He has inserted a pacemaker as you know, this patient has a previous history of STEMI and he did a surgery from before. You can see some sternotomy scars from before, although it's not as visible here. And on top of that, there's the presence of a moderate-sized left-sided pleural effusion. You could always tell this is a pleural effusion because of obliteration of the left lateral costophrenic angle. Compare the left lateral compared to the right lateral. So there's obliteration of the left lateral costophrenic angle, and therefore there's accumulation of fluid. And this fluid can accumulate to give the appearance of a meniscoid appearance, a U-shaped appearance. And you can see the presence of ciliate sign, where we can no longer see the left border of the heart as well as the edges of the left hemidiaphragm. And if we look at a lateral view, it will further confirm our suspicion that this is a case of left-sided, moderate-sized pleural effusion. You can see the posterior costophrenic angles obliterated, the left side specifically, because, you know, the right costophrenic angle, you know, this one right here, if we look at it from the posteriorly, is not obliterated because you can tell by the dome shaped of the right hemidiaphragm. But if we follow the left side, it's obliterated and there's accumulation of fluid, and there is basically an arc throughout this fluid, vertical diameter all the way across, and we can clearly see the presence of the two-lead pacemaker with one lead on the right atrium and the other on the right ventricle. So with a left-sided pleural effusion, with more or less maybe a case of cardiomegaly, enlarged cardiac silhouette, maybe, along with this patient's finding of fever and chest pain following a heart procedure, we will assume that this patient has Dressler syndrome or autoimmune pericarditis. And the medical treatment would be, as first line, a high dose of aspirin followed by colchicine to prevent recurrent attacks.